I'm Madhukar Trivedi, and by happenstance, I'm following the presentation on happiness with talking about depression. So I'm going to try to convey two messages. One is this is very common. This is actually a major cause of suicide. We hear about this all the time. It is not a new problem. It is very common, but it should be seen as a public health issue rather than just an isolated problem. And I'm going to talk a little about what it really means, and then there are very good solutions. So my focus actually is going to be on the hope related to it. How many of you are personally experienced or have somebody in your life who've had depression? If you could raise your hands. And this is very common. One of the things that I want to point out, all of you who did not raise your hands, is mainly because somebody in your life didn't tell you. This is a very common and yet a very silent illness. We just heard about reconnecting, about happiness, about choosing happiness. A typical patient coming to me is actually often telling me for something like the following. I am in a meeting or I am in a party and I feel alone, I feel lonely. These are people not choosing to be sad or depressed. This is really a very common thing, and I'm going to talk a little more about it. But imagine a world where we live in today where more people die from suicide than die from breast cancer. Double the number of people die from suicide than die from homicide. And yet, if you look at the real world, most of the attention is on crime, on violence, on homicide. We don't pay as much attention to this. There's about a 10 to 12-year lag between when somebody has the first onset of symptoms and their diagnosis is made. We don't tolerate this kind of thing for breast cancer, for colon cancer, for heart disease, for diabetes, but for depression we routinely allow that because, again, it is silent, it is hidden, and we don't really have a proactive system in place for this. So I'm going to give you some examples of how we are trying to do this in the North Texas area, but this is really spreading in many places. So depression should be seen as a treatable illness. I don't want you to walk away today feeling depressed about this. This is really treatable. There are very easy approaches, and one of the biggest things that we want community and society to really get engaged with, you and we need to demand a different approach, because what the biggest challenge with depression is we know a whole lot. We know how to diagnose, we know how to treat, we have many treatment options. Unfortunately, a lot of you may have heard it's medication, it's psychotherapy. It's actually all of the above. Our big task is to match people with the right treatment, and if we do that, then depression is treatable and suicide is preventable. And yet, most often when I hear or when I get any question about depression, it is when somebody is suicidal. It's like somebody paying attention to high blood pressure only when there is a stroke. Well, then that's really a very hard way to approach it. So we'll give you some examples of how we should do this. But one major thing we have begun to understand is it should be seen as a pediatric illness. 70% of people who have depression in their lives will have their onset just around puberty or up to that. And there is a large proportion that will have their onset first time they go away from home to college, etc. So that means if we focus on that group, we try to become proactive and not wait for a crisis, we actually can turn this around. And yet, we, as I mentioned earlier, we detect this too late. And remember, people, when teenagers, when they're just around puberty, there's a significant amount of pruning happening in the brain. Brain circuits are being laid out. That is when we figure out how best we are going to deal with negative emotions, emotion conflict, with reward, with how we enjoy things, how we develop relationships, etc. Those circuits are being laid down in the brain during that period. And if that period somebody has depression or anxiety, that really messes with the circuits, and that really has a big problem in the long run. So we should not avoid getting the right diagnosis. This is not, again, let me remind you, this is not a group of people who choose not to be happy. This is really a medical brain disease. And there's now ample evidence from brain imaging studies, from EEG studies we have published, others have published in the world, that clearly shows these circuits are dysfunctioning. They are not functioning well when somebody has depression. A very good example, if you run into some negative situation, somebody criticizes you, somebody actually does something wrong to you, you might feel negative for a little bit. When you go home, you sort it out, you work with somebody, you talk to somebody, and you next day are able to actually put it in context. Somebody who has depression, their circuits are dysfunctional such that that really throws them off for months on end. And that is really what we have seen with many studies. So while there is a big access problem, there's a big challenge with diagnosis, it remains hidden. It doesn't come with an easy to diagnose test, but we have actually advanced quite a bit in the last 20, 30 years. And I think the biggest challenge is we are not putting things into practice. We are not engaging in really societal change. Why should insurance for mental health be different from physical health? And yet, actually, any given health system in the country, even the best of it, mental health services are reimbursed in a very different way than physical health. As if, and you know, that just has not really helped our system. So, diagnosis is difficult, treatment often becomes difficult if you don't pay attention. What often happens is somebody gets a medication or a therapy and no monitoring happens. Nobody actually figures out how best to decide if the first treatment is really ideal or not. If the first doesn't work, you may have to go to the second or the third. This is routine in medicine. There is very few medical illnesses where there's only one treatment. 100 years after figuring out what to do with hypertension, we are still looking for new treatments for that subgroup of patients where the treatments we have don't work. So that kind of pursuit is necessary, but that doesn't mean the treatments we have don't work. We just have to figure out best way to do it. There has to be a solution that has to be more comprehensive. The Lancet Commission just came out with a report clearly recommending that we have to have a comprehensive approach that includes assessments, that includes implementation, that also may require research, obviously, further research. We are doing research with every medical condition, even those we have understood very well. For Huntington's disease, we know the gene that causes Huntington's disease, and yet research is needed in that. So just because there is research needed does not mean that we go away with saying we don't understand it. So, at least at the UT Southwestern Center, which we have established, our focus is first and foremost on prevention and early identification. That has to be the real core of what we do. First and foremost, if we know that treatments work, and if we can identify early and put in prevention measures, we can actually make a significant impact. The treatments we have need to be monitored very carefully and need to be associated with evaluation, assessment, measurements. If I ask a group of 100 people who have depression who are being treated and ask them, how do you know you're better? What tools are being used in your clinical practice by your providers? 98 of them will say, I don't know. They just ask me, how are you doing? So there are methods available we have put in place, and I'll show you those, and we'll need to develop blood and brain tests as we go forward. So we put in a thing called where we are partnering with primary care. Remember, in psychiatry and mental health, when somebody has a problem, first and foremost, we start running to find a specialist. Because the primary care, pediatric practice, OBGYN, does not actually make that routine part of their practice. If you have a headache and you start looking for a neurosurgeon, you'll have the same access problems for neurosurgeons as you have for mental health providers. That needs to change. And so we developed a partnership with primary care practices in town, put in measurement tools that are very well validated. These can be actually go up against any measurement tool in rest of medicine, and put in support structure for these primary care practices, and they routinely screen. Remember, again, if you wait for somebody's depression to be that obvious and wait for a crisis, that's been 10, 12 years. So we put it proactively, and we have now about 150,000 people who have been screened by primary care practices, not by mental health specialists. I'm a psychiatrist. I think that the patients go most often to their primary care and pediatric practice. If I again asked you all to raise your hands, there's very few people who will only be going to a mental health specialist, but most people go to a non-mental health specialist medical practitioner. That's where care happens. And this is possible. And if you look at the entire population of the United States in terms of people with depression, unfortunately, as I mentioned, half the people never get diagnosed. Remind you, half the people don't get diagnosed. If we did that with colon cancer, we as a society would actually not really tolerate it. But we do that with depression. If you do this routine screening and use measurements and do the system change that I'm talking about, then you can have almost 70% of people get into full remission. So this actually is not as hard as it sounds. It needs the will of the entire society. You are needed, mental health specialists are needed, primary care is needed to make this change. Otherwise, we are kind of doing almost more and more of the same. So, is that enough? Remember, that still gets you 30% of people for whom treatment may be still hard. So therefore, we have to develop blood tests. We've just published on a protein marker for depression. We also did an artificial intelligence-based EEG algorithm. Both of these help us actually with this group of patients who are not doing well with the standard treatments. And there are novel new treatments, including magnetic stimulation, et cetera, available, and more are coming down that will change this so that we can get to just as close to 100% as we can. There will still remain a small group who will have continue to have difficulties with the treatments we have, like with any other medical illness. But it's a shame that this large chunk of population that should get better doesn't get the attention from our systems. We have, as a result, been able to convince actually the state legislature supporting us to do this across the state, across the 12 major medical centers in the country, in the state, that are implementing this very process so that over the next 3 years, the entire state will actually have access to this approach that we are talking about. Finally, that will take care of people for whom depression has already, so to speak, arrived. We can and do much more with resilience building and prevention. And that is, again, another model to be brought from our experience with other medical illnesses like heart disease and diabetes, which is why there's so much emphasis on activity and exercise. That is why people talk about nutrition to prevent and reduce burden from diabetes and heart disease. For mental health issues, depression, that can easily be done. We have a very fascinating 5-session program in a lot of schools. We have been in the Plano ISD for the last 4 years, and I'll show a little bit of that data. The program is actually different from just giving lectures to students. These students actually get a 5-session experiential inductive program that allows them to become aware of mental health, about wellness, about resilience building. It raises their awareness so that they can seek help when needed, and actually has, I'll show you some of the data. We have had tens of schools in the North Texas area, and now we are taking this again statewide in order to be able to do this across the state. These are resilience building programs, so these are not designed necessarily for students only who have depression. So the entire classroom actually gets the program, and yet we will show you that it actually improves outcomes. So we have, in North Texas over the last 2016 to 19, we actually reached over 14,000 students, including in Plano ISD. 3,800 of them and their parents were good enough to actually allow us to get even more data from them. And you can see here, this is a general population of students. 6% of these students in high school had significant enough suicidal ideation that we had to take them to their counselor. In that group of students, obviously there's a whole large range of students who don't have depression, who don't have risks for that, and yet we were able to show reduction in depression and anxiety in this group. And so we are continuing this, and we'll take this statewide. These are the kinds of things that I think I'm going to leave you with. And the final thing is, all of what I just described requires one major aspect from society. My personal bias is, I would like for the entire population to become demanding, informed consumers. If, for example, I start getting my blood pressure measured on a regular basis at Walgreens, and it continues to go up, I'm going to call my primary care or my cardiologist and say, your treatment is not working, I need to do something. If I get measurement of my hemoglobin A1C, and that keeps on going, I'm going to call. Because people get more informed and educated, they then change their practice, they get the right treatment, and actually we can make a big difference.